So while everything favors decoupling and it favors high concentrate, what is the problem with decoupling? When the hemodynamic status of the potential organ donor is unstable, at the same time you have to have, according to current recommendation, an early referral to the OPO, then this becomes in the way of decoupling and giving enough time for discussion. And also there is an ethical dilemma with the physician who knows the patient is dead, but he has not had a chance to clarify with the family, and he or she will be giving hemodynamic support or organ support only for the preservation of organs with the purpose of organ donation. So there is a moral ethical dilemma here. You see, there is a decoupling between treatment and donation. The treating team and the people who initiate the organ donation conversation. So what is important to the treating team is to focus on the diagnosis of brain death, focus on the treatment options available, and focus on the prognosis, right? So this is the first job to be focused on before we enter into a conversation which we should use the OPO coordinator for. And that person should emphasize on the gifting aspect and on the social need aspect rather than on anything else. So if you can graphically represent this whole process, firstly we have to identify one who is a potential organ donor by the dead donor rule as the trajectory is progressing. So ICU screening. Then the physician is in conversation with the family. But when one can see that the disease trajectory is entering into the region of brain death, then early involvement of the coordinator, and then when the consent is given, then the physician takes up further conversation leading up to the actual donation. This is a paper by Siminoff, Factors Influencing Family Consent. There are 9 trauma hospitals in the US, all donor eligible cases. 420 were eligible, 238 had consent. So correlates for success were family's prior knowledge of the patient's wishes very high, more discussion and information very high, more contact with the OPO, that is the coordinator, also spends enough time in conversation and clarification. Optimal request pattern. One should say it will benefit others. This altruism should be emphasized rather than saying, I'm required to ask you. It's my duty to ask you. It's a protocol to ask you. No. Say it'll do good to others, right? Socio-cultural and communication variables we have to be sensitive to. We should speak in a language which is understandable, we speak without jargon, and we should be sensitive to feelings and emotions and listen more and have patience. So physician experiences with communicating organ donation with relatives. So a Dutch nationwide evaluation of factors that influence consent factors. You can see that this is a study between 2013 and 16. 32 specialists in organ donation. They're specially trained for organ donation. They systematically evaluated the requests through a standardized questionnaire. 1322 requests where next of kin decided were studied. Not those whose wishes and values were clearly known of the dead patient, but where this was not available. So the decision was made by the next of kin. The independent predictors of consent were requesting organ donation during conversation about futility of treatment. Okay, while the futility is being discussed at the same time, understanding of the term brain death, this is often a problem. We must spend enough time to explain what brain death is and give enough time for this to sink in and to be clarified. This needs a lot of patience and sensitivity. And consulting a donation expert prior to donation request, because they had trained donation experts, this carried the maximum odds ratio of 3.4.